This is Tracy, and I'm going to be talking about the pathophysiology of preeclampsia. Preeclampsia is a high blood pressure disorder developed during and after pregnancy. It can also be known as intrapartum or postpartum preeclampsia. Postpartum preeclampsia is believed to be a continuation of intrapartum preeclampsia that is usually missed due to signs and symptoms overlapping with what is deemed as normal pregnancy symptoms like headaches and swelling. It can also be missed due to misassessments like urine checks during prenatal appointments. Preeclampsia is diagnosed with two key factors: high blood pressure and proteinuria. It is diagnosed after 20 weeks of pregnancy with an elevated systolic blood pressure at 140 or greater than 140 and a diastolic blood pressure greater than 90. It is also diagnosed with the presence of protein in the urine greater than 0.03 grams per liter, which is a potential sign of multi-organ failure, or can be a potential sign of multi-organ failure. This is Tracy, and this is a continuation for the pathophysiology for preeclampsia. Preeclampsia is a multi-system vasospastic disease that affects organ perfusion. In preeclampsia, blood vessels in the body gets tighter and smaller, restricting blood flow. Due to tightening of the vessels, it's harder for the heart to pump blood through to the rest of the body, which in turn causes the blood pressure to go up. With less oxygen and nutrients reaching the important organs like the liver, the kidney, and the brain, it ends up leading to organ damage. Due to said damage, it is very easy for protein to leak into the urine, which in turn leads to proteinuria. When blood to the placenta is restricted or stopped, the fetus does not get the oxygen or the nutrients it needs for development. This ends up leading to complications like fetal hypoxia, birth abnormalities, and growth complications. This is Tracy, and I'm going to be talking about the signs and symptoms of preeclampsia. Hypertension is number one, which is the narrowing of the blood vessels, causing an increase in blood pressure. This can develop suddenly. 2 is headaches, which is increased pressure due to poor perfusion, usually severe and not relieved by medication. 3 is visual disturbance, which is due to possible swelling and irritation in the brain from elevated blood pressure. 4 is chest pain, which may indicate fluid in the lungs or heart strain from elevated blood pressure affecting blood flow. 5 is elevated liver enzymes, which are signs of liver damage, and is usually a complication of a worsening signs of preeclampsia known as the HELLP syndrome. There's proteinuria, which indicates the kidney is leaking protein into the urine due to damage caused by hypertension. It's usually diagnosed through a urine test. There's right epigastric pain, could potentially be from liver swelling, and often feels like a heartburn. There's decrease in urine output, which often shows signs of kidney damage. 9 is swelling, which is caused by fluid leaking into the blood vessels due to elevated blood pressure. There could be sudden swelling in the hands, face, and feet. 10 is sudden weight gain, usually from fluid retention. 11 are seizures and confusion, which is when preeclampsia is worsening into eclampsia. 12 is nausea and vomiting, which can be seen as normal pregnancy symptoms, but can also be indicated as worsening liver involvement. This is Tracy, and I'm going to be talking about the risk factors of preeclampsia. Risk factors are key points increasing negative likelihood of a disease. 1 is maternal age greater than 40. older maternal age is associated with blood flow and placenta problems due to vascular changes associated with aging. 2 is family history and past medical history of preeclampsia. Genetics or vascular tendencies or past medical histories of preeclampsia make it more likely for it to reoccur due to predisposition. 3 is gestational diabetes. Gestational diabetes can cause metabolic stress, which can lead to insulin resistance and inflammation. This can end up damaging the blood vessels, which can increase the risk of abnormal placenta function. Existing renal disease is number 4. The kidneys are already vulnerable during pregnancy, and an existing kidney disease can put it at a higher risk for damage. Same goes for chronic hypertension for number 5. It adds an additional stress affecting the heart and perfusion that can easily make it progress to preeclampsia. 6 is a pregnancy interval greater than 7 years. Long gaps can change the maternal immune tolerance, and the body may reset, leading to risks similar in the first pregnancy. 7 is null parity, also called first pregnancy. Encountering the fetal antigens for the first time can trigger an immune response, causing the mom's immune response to attack the baby. 8 is obesity. It can be linked to gestational diabetes, as it can cause inflammation, and it can also cause endothelial dysfunction, which affects the blood vessels. 9 is preterm labor, which is not usually a risk factor, but it's caused or it happens due to preeclampsia. 10 is C-section. C-section increases the high risk in developing preeclampsia. Surgery changes the structure of the uterus, like scarring, which may affect blood flow and placenta development. 11 is cardiac disease. A pre-existing cardiac disease puts stress on the heart, limiting blood flow demands for pregnancy. 12 is prenatal care. It can be related to socioeconomic factors like low income and lack of access to treatment or hospitals. This can affect early detection or early diagnosis.
Hi, this is Teo, and I'll be doing my part of the presentation. So first we'll start with tests and lab work for preeclampsia. So these tests help nurses and other healthcare team members to detect any complications early and manage preeclampsia effectively. So liver enzyme tests. Elevated levels are concerning and a feature of preeclampsia. So that would be AST, ALT, lactate dehydrogenase, and bilirubin. A complete blood count with platelets, coagulation profile, so body's ability to form clots, thrombosis, or risk of bleeding, including fibrinogen to assess for disseminated intravascular coagulation, electrolyte studies to evaluate renal function, and 24-hour urine collection for total protein excretion and creatinine clearance. Any additional assessments would be fetal health surveillance, electronic fetal monitoring, abdominal palpation, uterine tonicity evaluation, fetal size, activity, and position assessment. All right, and for diagnostics and relevant labs, so blood work would be liver function test, kidney functions, urine sample, platelet levels, vital signs, blood pressure is a really big one. Ultrasound of the fetus, CT and MRI for severe complications like headaches and seizures. We have an updated requirement for the diagnosis, so proteinuria was eliminated as a requirement just because it can have other causes, and this just allows for a more accurate diagnosis. Blood pressure, if it's greater or equal to 160/110 at 2 separate appointments. Your platelet count, if it's less than 100,000. Impaired liver function, elevated liver enzymes. Severe persistent right upper quadrant or epigastric pain, renal function, which is serum creatinine level greater than 1.1, pulmonary edema, and new onset cerebral and visual disturbance. So SPRE, which means Screening Program for Preeclampsia, is a research study that was done in 7 hospitals in England in 2016. They are comparing Bayes' theorem screen method, which is used in statistics, uses to calculate the probability of an outcome, which in this case involves the combination of maternal factors and biomarkers. So, and versus NICE guidelines, and NICE is National Institute for Health and Care Excellence, which is the current standard for identifying preeclampsia in pregnant women in the UK, based only on maternal characteristics and medical history. So in NICE criteria, if you have one of these major factors, you are at a high risk for preeclampsia. So that would be previous hypertensive disease in pregnancy, or chronic kidney disease, or autoimmune disease, example, lupus, or diabetes, or chronic hypertension. In the NICE criteria as well, if you have 2 moderate risk factors, you're at high risk for preeclampsia. That would be first pregnancy and maternal age of 40 and above, interpregnancy interval of above 10 years, BMI of greater or equal to 35, and family history of preeclampsia. And then SPRE states that Bayes' theorem does a better job predicting preeclampsia in the first trimester, so between 1 to 13 weeks, compared to NICE. So to continue on, Bayes' theory also includes maternal factors, but is also weighed with biomarkers that reflect placental and vascular health, very important. So such as mean arterial pressure, which elevated levels means an increase in cardiovascular stress. We have uterine artery pulsatility index. It's an ultrasound that measures uterine blood flow resistance. A high value would mean impaired placental perfusion. We have pregnancy-associated plasma protein A. Low levels of placental protein in maternal blood means poor placental development. And then placental growth factor, angiogenic factor for placental blood vessel growth, meaning low levels are a strong predictor of preterm preeclampsia. So aspirin is also used in preeclampsia prevention. It reduces inflammation, improves placental blood flow, and inhibits blood clotting. So NICE recommends that the women who meet the high risk criteria based on maternal factors only should be taking 75 milligram aspirin once daily from the first trimester until delivery. Problem is that the NICE criteria has a poor identification of high-risk women, and only 23% of high-risk women actually took aspirin, just because low compliance. SPRE study states that if using Bayes' theory as well as the biomarkers, not just the maternal factors, which identifies more accurately the women at high risk for preeclampsia, then aspirin can be targeted earlier, preventing dangerous cases of preterm preeclampsia. So when you look at the NICE guidelines, all preeclampsia detection, 30.4%, preterm preeclampsia detection, 40.8%, and for aspirin, only 23% of high-risk women followed that recommendation. And when we look at Bayes' theorem-based screening, all preeclampsia detection, 42.5%. Preterm preeclampsia detection, 69. That's with the maternal factors and the biomarkers. And preterm preeclampsia detection got bumped to 82.4 because we added that those extra biomarkers. So it bumped it up a lot. Compared to NICE guidelines, 20% difference. So in conclusion, Bayes screening doubles the detection rate for preterm preeclampsia compared to with the NICE guidelines. Last but not least, nursing interventions. So constant monitoring vital signs, especially blood pressure, fetal heart rate, urine output, and neurological status. Medication administration. So antihypertensives as prescribed, magnesium sulfate for seizure prophylaxis, and corticosteroids for fetal lung maturation if less than 35 weeks gestation. Patient positioning. Left lateral position to improve uteroplacental blood flow. And then we have fluid balance, so monitoring intake and output to prevent that fluid overflow. And with that, assess for signs of pulmonary edema. Education, so explain the condition, symptoms to report, and treatment plan. Provide emotional support to patient and family. As well as prepping for possible delivery, so coordinating with healthcare team for potential emergent delivery, because sometimes early delivery is recommended to avoid risk of maternal mortality. This may be the only cure. We have pain management, so assess for headaches and administer pain relief as prescribed. And postpartum care, so continue monitoring for at least 48 hours after delivery. Assess for signs of HELP syndrome. It can still persist and continue shortly after birth, so postpartum. And then at the next slide, I did provide a picture. So yeah.
This is Jennifer, and I'll be talking about the complications and emergency management in preeclampsia. Starting with the complications, eclampsia means seizures caused by very high blood pressure. When this happens, the brain becomes irritated and the mother can lose consciousness or convulse. It's life-threatening and needs immediate care. HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelet count. It's basically a severe form of preeclampsia that affects the liver and blood. The liver can become damaged and blood can't clot properly, which increases the risk of bleeding. Placental abruption happens when the placenta separates from the uterus before the baby is born. This can cause heavy bleeding and reduce the baby's oxygen supply. Pulmonary edema is when fluids build up in the lungs, making it hard to breathe. Acute kidney injury can also happen because high blood pressure reduces blood flow to the kidneys. In some severe cases, the liver can rupture or bleed internally. High blood pressure can also cause a stroke or brain bleed, which is cerebral hemorrhage. Disseminated intravesicular coagulation, or DIC, means the body's clotting system becomes overactive. Tiny clots form throughout the body, using up clotting factors and increasing bleeding risks. For the baby, complications can include growth restriction, because there's less blood reaching the placenta, being born too early, or even fetal death if the condition isn't treated quickly. Now moving on to emergency management. Any patients with preeclampsia or eclampsia needs to be admitted to the hospital for close monitoring. Nurses should make sure the airway is clear and oxygen is given if needed. Blood pressure is controlled with antihypertensive medications to prevent stroke or further complications. Magnesium sulfate is used to prevent or stop seizures. This is a key nursing responsibility to monitor. Both the mother and baby need continuous monitoring to check for signs of distress. Blood tests are done often to track liver function, kidney function, and blood counts. Fluids should be given carefully because too much fluid can worsen lung problems like pulmonary edema. The nurse can also help prepare for a possible emergency delivery if the mother or baby's condition worsens. This is Jennifer, and I'll be talking about preeclampsia treatment options. Starting with number 1, early detection and frequent monitoring. Frequent blood pressure checks help identify rising trends early. Urine testing for protein is done to detect kidney involvement. Regular prenatal visits allow for close maternal and fetal assessment. Ultrasounds are used to monitor fetal growth and ensure the placenta is functioning properly. Number 2, medications. Antihypertensives are used to control blood pressure and prevent complications such as stroke. Blood pressure must be controlled closely to prevent a sudden drop that could reduce placental perfusion. Seizure prophylaxis. Magnesium sulfate is administered to prevent seizures, monitor reflex, respirations, and urine output for signs of toxicity. Keep calcium gluconate at the bedside as the antidote. Corticosteroids. These are given only if the pregnancy is less than 34 weeks to promote fetal lung maturity. 3. Lifestyle and supportive care. Encourage bed rest and resting in the left lateral position to promote utero-placental blood flow. Reduce stress and avoid excessive fluid intake to decrease the risk of pulmonary edema. 4. Timing of delivery. For mild preeclampsia, delivery may be delayed if the mother is stable and under 37 weeks. For severe cases, plan for delivery once the mother is stabilized, typically after 34 weeks. Emergency delivery may be required for eclampsia, HELP syndrome, placental abruption, or fetal distress. Number 5, postpartum care. Continue monitoring blood pressure for at least 72 hours after delivery, as preeclampsia can worsen postpartum. Watch for symptoms like headaches, vision changes, or swelling. This is Jennifer, and I'm going to be talking about patient education in preeclampsia. First, you're going to want to explain what preeclampsia is to your patient in the way that they're able to understand. You can explain it's high blood pressure after 20 weeks of pregnancy with protein in the urine and other organ involvement. Reassure them they did nothing wrong to get this, but emphasize the importance of close monitoring for both the mother and the fetus. Explain warning signs of preeclampsia to your patient so they're able to catch it early. If the patient experiences any of the following, they should report immediately to their healthcare provider or emergency department. Severe headache that won't resolve, blurred vision, swelling in the face or hands, severe pain in the upper right abdomen or shoulder, sudden weight gain, decreased urine output, shortness of breath, chest pain, and vaginal bleeding. In terms of lifestyle instructions, you should direct your patient to rest in the left lateral position several times a day to promote blood flow to the baby. They should also follow a low sodium, high protein diet and monitor blood pressure at home. In terms of delivery planning, explain to the patient that delivering the baby is the only cure to preeclampsia and that other treatments are temporary. Inform the patient that there may be a possibility of a C-section or early induction. This way, they know that their birth plan may need to be flexible. Discuss the possibility of using corticosteroids for lung development in preterm birth. To summarize patient education overall, it's important to have clear communication when educating your patient. This can include an in-person private discussion, educational take-home material, and videos. The education is greatly important because it allows the mother or family members to detect preeclampsia and its warning signs early, and as a result could save the life of both the mother and the fetus.